Yay. As you all know, GECO is hosted by the Gastro Foundation in collaboration with Project ECHO, and we're very thankful for the support that we've had this year. We've had 58 registrations from 15 countries within Africa. So I'm grateful again for the registrations. And today, I think what we're going to discuss is a very important topic and probably a nice way to end the year. And the session has been coordinated by Dr. David Epstein, who you all know. I don't think he needs any introduction. And I'm going to hand over to David to introduce the session as well as the speakers. As the talks are going on, the chat will be open for questions. And thereafter, of course, we'll have an interactive session to discuss whatever comments or questions that you may have. David, over to you, and thank you so much for organizing this.
Thanks, Desh, and thanks to the ECHO team for the opportunity to speak. So I've entitled this talk, Inflammatory Bowel Disease, the Challenges of IBD Care in Africa. And we met, a few of us who have a loose association, have been meeting and discussing this presentation and really what are the challenges of managing care in the various countries in Sub-Saharan Africa. And I'm very pleased to have a number of colleagues that have joined me in this presentation. So just about Ibd Africa, we are a non-profit organization. We've been 3 years, we've been active for 3 years, and really we have a mandate to improve the care for IBD patients in Sub-Saharan Africa, and we hope to do that or achieve that through research, education, and advocacy. So why the need for IBD Africa? I think we recognize that there are more people living with IBD in Sub-Saharan Africa, and patients in this region have unique challenges. We have a large infectious diseases burden, there's a lack of diagnostic resources. We also recognize that there's limited access to treatment, and there's a very poor understanding of IBD by regulators and funders, and also limited patient education, and patient advocacy for IBD patients is almost non-existent compared to in developed countries. There is a recent interest in IBD in Africa. We've seen the emergence of a number of organizations over the last 3 years who have an interest in IBD or partly in IBD in the continent. And this includes GASA and the process that Chris is driving. We've got the Emerging Nations Consortium, we've got the BRICS IBD Consortium, and the WGO also has a foundation that focuses on developing skills and capacity in gastroenterology in developing countries. We've also seen a number of articles that have appeared in the literature for the first time looking at inflammatory bowel disease in Sub-Saharan Africa. I think the gap is original research. We have very little in terms of original research, and really the reviews are an accumulation of all the case presentations and other bits and pieces that have helped us to try and understand what is happening in terms of IBD in Sub-Saharan Africa. So what is the lived reality of IBD patients in Sub-Saharan Africa? We've had some presentations previously of patients in East Africa who've had a very difficult time, and we're starting to get a sense of the challenges of what many of these patients face. And we met as a group of doctors and activists from 7 countries to discuss what are the challenges. So we've focused on 3 areas. One is accurate epidemiology, and without recognizing the scale of the problem, there's really not much that can be done until we recognize how many patients are living with IBD in Sub-Saharan Africa. The second is accurate diagnosis, and this is something that we're all familiar with and has been discussed in detail at many of these fora on how to diagnose IBD and how to improve capacity in Africa. And then the third component is access to treatment. It's all very well understanding the epidemiology, making the diagnosis, but can these patients get adequate treatment? So what about IBD epidemiology? Well, we've got some data from Cape Town, from our Ibd Africa registry, that shows that there's a significant increase in the number of patients that are being diagnosed every year But what do we know about IBD epidemiology in the rest of Sub-Saharan Africa? And Phoebe Hodges is going to speak to us on her project based out of Lusaka, Zambia, on her IBD epidemiology project. What about accurate diagnosis? So how many patients in Sub-Saharan Africa go undiagnosed? We don't know, but this is just an interesting paper from Malawi that showed that almost 20% of patients with depression were incorrectly treated for malaria when they presented to a primary health clinic. And we suspect there could be a very similar scenario in terms of IBD diagnosis. And Yao Awuku from Ghana is going to talk about his experience with IBD diagnosis from Ghana. And lastly, we're going to talk about access to treatment. And this is just from our group, some of the figures that we've put together. So if one looks at the monthly income based on data from South Africa, Kenya, Zambia, and Namibia, we can see there's quite a large spread of incomes. I mean, this is not surprising. And then if we look at the costs of medication in the various countries, I think the first thing that's very clear, methotrexate is the cheapest IBD drug in all countries, and really should be on top of the list of medical formularies for treating IBD in Sub-Saharan Africa. If one looks at income and cost of medication, it's absolutely imperative that patients with IBD, particularly Crohn's disease, or with patients with Crohn's disease, should be on methotrexate from the get-go. Then look at the spread of azathioprine. It costs $16 for a treatment in Zambia, $65 in South Africa, but can be as much as $144 in Kenya. I think I've gone through all the others, but maybe two things I'd highlight. The cost of full dose 5-ASA in Kenya costs almost $300. That same amount of money can buy you a biosimilar in South Africa almost. So we see huge disparities in terms of the costs of medication in various countries. And this is obviously a huge obstacle in getting patients onto treatment. And Smita Devani from Nairobi, Kenya, is going to talk about some innovative techniques that they've developed in getting patients onto treatment. So without further ado, I think I'm going to hand over to Phoebe, and I'll advance the slides, and Phoebe's going to talk about her epidemiology project.
Thank you very much, David, and thanks for asking me to present this. And so I'm Phoebe. I'm a gastroenterology trainee from the UK, but I've been based in Zambia for the last 2 years, where I've been working on a PhD largely based on the role of environmental exposures in IBD in Zambians. But as a sort of side project nested into that, I'm also sort of running an epidemiology study, which I'm going to tell you a bit about over the next few slides. I'd be grateful if you could just show the first slide, please. Thank you. So as David has already said, paucity of data on epidemiology of inflammatory bowel disease is a big problem in Africa, and we can't really plan patient care, and we can't really know what sort of research studies are needed unless we have a better idea about what the epidemiology actually is. And the majority of publications, as you've already heard, have been in the form of case reports and case series. There was a 2017 systematic review which was published, I think, in The Lancet, which looked at global population-based IBD studies in the 21st century. And it included only one study from the African continent which met the criteria for inclusion, and that was from Algeria. And a more recent review, which was published, I think, last year, actually by David and colleagues, found only 3 epidemiological studies reporting on IBD incidents from Sub-Saharan Africa, and all of those were from South Africa. The available evidence, including sort of unpublished observations, does suggest that incidence is rising in the region, but we do need more accurate data about this. So that's part of what I'm trying to do. Next slide, please. So I've set up something that I'm calling the IBD Case Reporting Network using a tool called RedCap, which is an online data capture application which allows you to build and maintain databases and surveys. And the aim of this is to try and just gain more information about incidents through setting up a network of clinicians based across Africa who are seeing and diagnosing new patients with inflammatory bowel disease and asking them to report new cases on a monthly basis. So the way that this works is that every month all participating clinicians will get an email asking if they've seen any new cases in the past month. And then if they have, just asking for a few demographic details and also details about the disease. So is it UC, is it Crohn's? And then any investigations that have been done to date. So this is not patient identifiable in any way. So the demographic details are sort of fairly vague in that we ask for patient's year of birth and I think month of birth, and then the region that they live in, so the region and the country. So it should be impossible to identify individuals through this database. And of course, this is a sort of collaborative project, so any publications resulting from this eventually will be credited to all participating network members equally. Next slide, please. So who can participate? Well, anyone working, any clinician working in Africa who sees and diagnoses IBD patients. I was particularly interested in incidents in Sub-Saharan Africa. As you've heard, that's really where the main sort of data gap is. But anyone really on the continent who is seeing and diagnosing these patients. And it works, as I've said, so you initially get an activation survey, which is just a yes or no, do you agree to participate in this project? And then following this, every month you receive an email asking if you've seen any new cases. And then following that, a further communication asking for a few details. So I'm just going to show you what that looks like on the next slide. So this is the follow-up survey. So if you answer yes to the question, have you seen any new patients in the last month, you then get a follow-up survey asking for a few details. And some of these fields actually have branching logic. So when you say, for example, if you've said yes, the patient did have an endoscopy, a field will then appear asking just, you know, what were the endoscopy findings, just briefly. And these are not mandatory fields. So for example, if you can't summarize biochemistry or hematology results, you can still submit the form without these. And next slide, please. Just a few very brief initial results. So I set this up sort of earlier on this year around April time, but it only really started to gain some traction probably around June or July. So I don't have a huge amount of data yet, but so far we have 36 participants in the network with the following numbers from each country. So I think it's sort of 11 countries so far. And since the inception of the network, 57 new cases have been reported. And you can see that the majority of those have actually been from Ethiopia. So over a quarter of the cases that have been reported since the setup of the network have been reported from Ethiopia, with a few, I think the next most frequent reporters were in Sudan, despite not very many network members being based in these countries. So I think there's 3 each in Ethiopia and Sudan, which is quite interesting. Obviously, we have the highest number of respondents in Nigeria, which I guess reflects the population of that country. And yeah, I've just given a breakdown in terms of sort of frequency of cases being reported. This obviously does depend on people signing up and participating. So on the next slide, I've just put some details about how you can do that and get involved if you're interested. Yeah, thank you. So please just send me an email. I'll put my email address up here and let me know if you'd like to be involved, and I'll send you the activation link, and that's it really. And following that, you'll get a survey every month just asking if you've seen any new cases. And I hope that this will provide some useful information about incidents on the continent, particularly in Sub-Saharan Africa, which might allow us to sort of plan future research projects, but also will provide a basis for sort of planning patient services as well, because it's impossible to do that really without knowing what the incidence actually is. So thank you very much for listening and for the opportunity to present this project.
Great, thanks, Fee. That was excellent. And I think there are lots of interesting questions. I think we'll save all the questions for the end of the presentations. So next is Yao Awuku, who's based in Ghana and spent some time in Cape Town training in gastroenterology. And his comment in our sort of initial workshop was the problem of accurate diagnosis in Ghana, and he's going to present some cases highlighting many of the challenges. Thanks, Yao. I'll advance the slides for you.
Okay, thanks, David. So I think the background has been set already, and we're speaking to the topic challenges of IBD care in Africa. David, we can go to the next one. And my focus is just going to be on IBD diagnosis. We can go to the next one. I've been introduced already. Yeah, so my outline, 2-case presentation. I'll do some highlights of IBD diagnostic challenges when it comes to Ghana. Right, so a 30-year-old, I presented this case, but I just use an aspect of it to focus on the discussion for today. A 30-year-old female with intestinal obstruction, laparotomy done 2019. He had several other surgeries done. In the first surgery, they found a small bowel stricture, which did not prompt anyone that possibly this could be Crohn's disease. He had a second and third laparotomy on account of a pelvic abscess. They had a resection of part of the small bowel done. He was referred to a second hospital for a third and fourth laparotomy, breakdown of the suture site. They had to do a refreshment of the edges and then resuturing for this patient again. Next. So finally, the patient had a loop colostomy done at the same surgery on account of an enterocutaneous fistula. He was discharged home for follow-up. Unfortunately, they took the samples for histology. So this patient was actually awaiting histology. Surgery was done to reverse this colostomy. The patient actually self-referred to a facility where I work. And I actually wanted to go back to look at the past medical history. How has she been like? She actually gave me a history of an intermittent mouth ulcers at the age of 18 years, which became persistent from the age of 25. She also had bloody stools with crampy abdominal pain in the past before the surgery. She had general joint pain with severe lower back pain to the extent that she actually ended up with a neurosurgeon consult, that MRI was done, physiotherapy followed up. She has had repeated blood transfusion from the age of 18 years. And finally, she actually confirmed to me and showed a report that she actually had a right hemicolectomy done at the age of 21 years on account of an appendiceal mass abscess, which was not so clear with. Next. So this patient actually had a self-referral, and looking at the age, as I talked to you about, started from the age of 18, 21 years, had a hemicolectomy until 31 years when the diagnosis of Crohn's disease was actually made. Here, she presented with a progressive weight loss, multiple bowel surgeries on account of intestinal obstruction, which I had highlighted earlier on, and a histological diagnosis of Crohn's disease from the most recent surgery that she had. On presentation, this patient had a right iliac fossa pain. He had a fever. Ultrasound demonstrated an inflammatory mass in the right iliac fossa with a temperature of 38 degrees Celsius, palpable mass at the right iliac fossa. These labs, fortunately, were able to do it in my part of the world. CRP, of course, we were able to get it within 24 hours, but it takes over 2 weeks to actually get a fecal calprotectin results. And usually from one laboratory, MDS Lancet, I'm sure is an association with South Africa lab where we're able to get this result. And turnaround time is 24 hours. And this, how to call it, 2 weeks at least. And this actually turned out to be 319. And together with the past history and all that, we're able to confirm the diagnosis of Crohn's disease with the histological diagnosis as well. Next. So just want to summarize the journey so far. I did not go into the therapeutics and other aspects which I presented before, but this was our patient before. So much wasted. He had a weight of about 59, and this patient is now looking so great and is happy. We were able to go through many letters. I wrote over 50 letters to be able to get sponsorship for Infliximab, which is currently on, and this patient is doing so well. We can go to a second case. Yeah, so this is patient HA, who is a 40-year-old female with a 6-year history of diarrhea, progressive weight loss. She's lost about 20 kg, and her current weight at presentation was 50 kg. She also complained of anal pain with discomfort. Averagely, which she had accepted as a normal part of her bowel, was that she has 8 to 10 loose stools per day. She had had several courses of antibiotics. She had had many anti-diarrhea medication. She had tried many alternate medicine, and she still has these symptoms actually persistent. Next, David. In terms of her examination, these were the significant findings. This was a depressed young lady with evidence of wasting. And like I said, her weight at presentation was 50 kg. There was a tender digital rectal examination, and there were perianal fistulae, which you can actually see vividly on your examination. Next. So this patient was referred from her hometown to the capital city in Accra. What it means is that if you, later on I'll highlight on some of the challenges when it comes to diagnosis and the skewed distribution of gastroenterologists as well as endoscopy services in Ghana. So at presentation, her CRP when we did it was 49. Fecal calprotectin that was requested took about 2 weeks to come, but this is a summary, so I just showed the figure that we got in all. A lower GI endoscopy was booked for, and they had to move to where we have the endoscopy to stay over and spend a day or two for this to be done. And when we did endoscopy, her endoscopic features were classic textbook description of what inflammatory bowel disease actually shows us. And so this is one of the pictures that we show with severe colitis. The next slide. There were a number of these slides in various segments, which, and these also as well were also shown. The other pictures which I did not show. So biopsies were taken for histology. And we can go to the next one. I would talk about what the histology showed. We actually requested for abdominopelvic MRI, which it took a lot of fundraising to be able to arrive at this. And the conclusion of it was that there was edematous changes in the rectum, sigmoid colon, and distal descending colon, which was in keeping with the earlier lower GI endoscopy that we had done. Minimal free fluid in the peritoneal cavity, and of note is also of perianal fistula, which the MRI reported. I've put the histology report here, which you can go through, but the conclusion, which later I'll talk about, was a non-specific rectal ulcer. From all the images that are shown earlier on, it shows some of the challenges in terms of concluding or being confident about the diagnosis that we were actually looking for. Next, David. So the journey so far for this patient, we made a decision based on the history, other findings that we had made from her, a diagnosis of Crohn's disease. We started on prednisolone and azathioprine where we were trying to look for funding, because this is a patient who actually requires infliximab, significant colitis with perianal fistulas. That was very uncomfortable for this patient. Finally, we were able to do that, and she's had her time 0 and 2 weeks now, waiting for the 6 weeks one to be given. In her last visit, that was a week ago when I saw this patient. This was an elated young woman out of a depression without antidepressant, with clinical and biochemical remission. We have not repeated the lower GI endoscopy for biopsies for follow-up of this patient yet. Next, David.
Thanks, Yal. That was, that was a lot to discuss in those two cases. And yeah, I mean, you've just highlighted so many points that you know, just make care in South Africa seem very easy. I'm just going to ask Smita Devani from Kenya to just chat on some of her experience in how to get patients onto treatment. Smita has an excellent, provides an excellent service in Nairobi. She has a large patient group. You know, they seem to have access to endoscopy and to various imaging, but treatment seems to still be the problem. And Smita was telling me at our last sort of meeting that they have innovative ways of getting patients onto treatment. And I thought maybe this was something that we could learn about and maybe apply in other countries. So Smita, if you could just give us an idea of how you get patients onto treatment in Kenya.
Yeah, thank you, David. So yeah, the financial challenges remain in Kenya. However, Nairobi being the hub of care, often patients do tend to gravitate towards, sorry, I'm just trying to get the video on, I don't know.
That's all right, we can hear you.
That's okay, you're good?
Yeah.
Okay, so often the patients land up in Nairobi and can land up at Aga Khan Hospital, where my main base is. And we can, of course, provide a lot of colonoscopic care, CT enterography. MR enterography is not very well developed here, but CT enterography is. So we tend to use that, especially for Crohn's disease. We do have capsule endoscopy, so do we, but we don't have the endoscopes yet. So pretty much we are good with most of the diagnostic tools. Our pathologists do help us out, and calprotectin levels also tend to take a bit of a time, but we do get it within a week or so. Actually, we have some pathology labs which send the results to South Africa, mainly Lancet Laboratories. So we tend to get the results fairly quickly. The diagnostic acumen, of course, is very important in this situation. And most of our gastroenterologists are now either trained from South Africa itself, or it could be that they're trained in the UK and they'll come back. So we have a good gastroenterology base here now. So when it comes to treatment, obviously the prednisolone remains very cheap, and it may be a go-to treatment initially. However, I try to avoid prednisolone as much as I can, but in some instances, it is necessary to have patients on it. Mesacol, it goes from about $100 to $200 per month, and I'm using dollars, but we do have now some treatment centers where we can actually get it for $100. I'll talk about this interesting concept which has been launched recently. The azathioprine is freely available. So is methotrexate, so is 6-mercaptopurine. But biologics tend to be expensive. And unfortunately, much as the companies do try to get us 342, but it still remains out of bounds for most of the people. What we have launched, and I'm pleased to say we've been part of it, is a low-cost treatment, where you can actually get colonoscopies done, all the treatments done at about 60% of what main centers in Nairobi would present. And so we can do the colonoscopies and also get the treatments much cheaper because the markup is very low. The other thing we have worked with is India. We do have some people who go to India and get their own treatment, but they bring extra for patients. So we actually share their treatment, so to speak. And the Mesacol and the enemas tend to be much cheaper when we get them from India. The other thing we have also tried to use is just getting people to donate money for this procedure. And we use that as a funding. But basically my idea is that I'm going to try and get drug companies to lower their prices. Number two, we try and also get more funding together so that the patients who can't afford those expensive treatments, we can try and get cheaper brands. Biosimilars are being worked on, and we are hoping to start getting some biosimilars, but we don't have them yet. So we have been working around different treatments and seeing how we can work. One problem we have had, and I don't know, David, if this is a problem in South Africa as well, trying to get Predsol enema. I used to get Predsol pretty easily, but recently I found that it's very, very difficult to get it from either UK or India. Is that your experience too?
Yes, I think that's also been a problem here, that we can get, we've got a budesonide enema, which is a liquid, but a lot of people have inquired about sort of getting foams and things like that, which we can't get. But we do have just a budesonide enema, or intercourt enema, which is available, but very costly. I mean, it is exorbitant here in South Africa.
Yeah, we do have budesonide here. I have some patients on it, probably about 4 or 5 patients of budesonide, 3 milligrams, but then we put it to 9 milligrams. So we have some patients on budesonide, but it tends to be pretty expensive as well. So we are trying to work around different systems to try and get more patients who can afford the treatment. But at the moment, biologics seem to be out of most pockets, except for some well-to-do or good insurance patients. But I'm hoping biosimilars will tend to change the scenario in Nairobi. Thank you.
Great, thanks, Smita. Okay, I think maybe we could start the discussion. Mesh, I don't know if you want to.
Yes, thank you, David, and thank you to all the speakers. I mean, I think you've all brought out such important points, and we did have this conversation or a similar conversation at SAGES about how do we start to address IBD pickup, diagnostics, pathology, and of course treatment, which David has done a lot of work in terms of advocacy. I was just wondering, Phoebe, I was quite interested to see that in such a short space of time, you have identified 50-something odd cases. I mean, when Jill did the review that was published, I think a year or so ago, she found about 50-something cases in all of Africa since time immemorial, which, and you know, she argued that it can't be true. It just is a reflection of the fact that we don't have data, or data is not being collected, or is not being collected properly or adequately. So I think your Red Cap registry is a fantastic venture, I think, to try and get what the numbers actually are. And as David has said, we do expect that they are on the rise. They have been, we just have not really picked it up. I was wondering how much exposure you've had to many other people all over Africa, you know, to let them know of your registry, because I think it truly is an important venture.
Thank you. Yeah, I mean, I think this organization has been extremely helpful in publicizing the network, because initially I was sort of trying to approach people through just, you know, contacts with my supervisor, but Gecko's actually been extremely helpful in sort of putting the word out. So most of the participants in the network have come from your organization, actually. So that's been very good. I think things like medical associations, the good thing about trying to find clinicians who are diagnosing IBD is that actually there's probably not that many of them. So I think, and certainly in countries like Zambia, so here we have only 2 government endoscopy units in Lusaka. And I think there's one on the Copperbelt, and most of the endoscopists who work at other private hospitals are also government employees. So it's very easy to know who will be seeing, you know, those cases and making that diagnosis. So certainly in country, it's quite a simple matter to sort of identify those people and then ask them just to sort of let me know about their cases. And I think that maybe that's the case for quite a few other countries in the region. Although I obviously can't speak for other people, but I think the main thing is networks like this, who you know, where people are inherently interested in this subject and are going to also spread the word, hopefully, to their colleagues. So that's my hope, anyway.
Yeah. Chris, I mean, maybe beyond this ECHO platform, is there a way that we can use the foundation website, you know, to propagate this Red Cap registry, and even other ways within the GF activities?
Yeah, well, thanks a lot. And thank you very much. I think this has been very useful, David, Smita, and Phoebe. So Phoebe contacted me. So let's just clarify. It's not the foundation that, you know, assisted Phoebe. It was GASA. So we've got the GASA network, which is really just a loose association, but it's becoming very important in networking, allowing people to know what's going on in Africa. I sit on a lot of boards, endoscopic, liver, IBD, and what you hear is, didn't know that this is happening in the Sudan or in Kenya or in Sierra Leone. I wish we had known. And I feel that there's a lot of good things that are happening in Sub-Saharan Africa. Not everyone knows about them. So we encourage everyone to to push all the information through the GASA portal, which Cheryl runs. It's just a networking of emails. So all we did was we just introduced Phoebe to that portal. So it's the GASA portal, not the foundation. The foundation is really just the parent body. And also to congratulate Jill, because it was really through that too, and also her publication in the ECMJ, that the Lancet approached to do the important reviews, which we're holding thumbs. But I mean, I'm going to ask Jill to follow on me and give some comments. So I encourage you all to use that portal. It seems to be effective. The hepatologists are driving hepatitis C through and B through it, liver cancer through it. MAFLD has just been published through that kind of networking. So it is an effective way of communicating. Just one question as far as treatment's concerned. Mash, I mean, you've just reviewed thalidomide as a possible alternative to biologic, and I mean, you used David's case. And I just wanted to ask David and you, Masheko, whether thalidomide might not be an option until we get biosimilars established in Sub-Saharan Africa.
I'm happy to go first, and then David can maybe corroborate. So, I mean, we are punting it as a treatment for second line or failed third line therapy. So I still wouldn't suggest that, you know, that would be the first go-to place. But it's interesting because just before I was preparing my presentation, Jill asked me, you know, it's actually quite costly. So once it was repurposed as a drug for myeloma and potentially for refractory Crohn's disease, the price has simply shot up. So thalidomide can cost, depending on what dose you prescribe, and generally if you're just costing it over a year, it can cost anything from 25,000, 30,000 to 200,000 if your dose ranges from 50 milligrams per day to 400 milligrams per day. So it's not cheap. So I don't know where it's going to fall in terms of sequencing and whether maybe it's a little bit cheaper than biologics, but maybe not biologics. David, I don't know what you think, because you actually have used it in private.
Yes, I've used it in a few patients. Look, it's a nasty drug. It's got terrible side effects, drowsiness, sedation, and peripheral neuropathy and thromboembolic problems. And so it's, and you know, obviously the issue with fertility and you know, we see a lot of young people's Crohn's. So, and it's expensive. So I think for so many reasons, it's not a great drug in resource poor settings. In fact, I think you've got to use it in quite sort of sophisticated settings where there's a lot of close monitoring and, you know, to watch out for complications.
So then we're going to resort to steroids, I mean, acutely to bring things under control, and then using immune suppressive therapy, of which you said methotrexate should be one to consider, and cautious, use in young women who are fertile. And then, I mean, I would be happy with very low dose chronic steroids, 7.5 milligrams in the absence of anything else, if that's the only thing that will control them.
Sure.
Jill, perhaps your comments, and how do you see Sub-Saharan Africa after your brilliant work, which is yet to be published, but which I'm confident will be?
Okay, so just a couple of things. So what it appears is that certainly outside of South Africa, ulcerative colitis is by far the commonest phenotype. And I think Smita's brilliant database just shows that very conclusively. And of course, methotrexate doesn't work in ulcerative colitis. So that's a problem. The second thing is biosimilars really should become available. As Dave pointed out to me the other day, you can now get adalimumab biosimilar, which is actually even cheaper than a full dose of 5 ASAs for a year. And what's been interesting is over recent years, it's become clear is if you have to escalate a patient onto a biosimilar and they've been on a 5 ASA, you can stop the 5 ASA. You do not need to continue it. So this would in fact be an incredibly cheaper option in that case than actually adding on a biosimilar to existing 5 ASAs.
Yeah, I would
agree. There's a reluctance David, for industry to go into Sub-Saharan Africa with biologics because of the TB risk.
Chris, maybe just one comment. When I speak to industry representatives, because I just can't understand the the discrepancies in the pricing, that why in a resource poor environment you're paying double for the same drug, that in South Africa, which is relatively well resourced, it's half the price. And and my understanding, and maybe others who have more knowledge of how the industry works, is that there is an issue with different prices for different countries. That the companies have protocols that they cannot sell one drug cheaper in Zambia, for example, and more expensive in South Africa. And that a lot of the pricing is region-based. So there's Africa, Middle East, there's Europe, there's Asia, and the prices are for that region. I just think it's unfortunate that patients with this illness in countries where income is less have to pay more, way beyond the means of those patients. And that's just the way the industry works, and that's my understanding of it. So that's
it is the way industry works, and until such time as you have advocacy both from doctors and patients, it really doesn't change, because the change is not going to come from industry.
And I think the one thing is competition. We've seen that the price of biologics has dropped dramatically as competitions come into the market. Whereas products, a lot of the 5 ASAs are original products with no generics. So those prices have remained high, and they haven't dropped. So that's just an issue on pricing. I just wanted to maybe also comment on Phoebe's presentation, and just the fact that you've got 11 countries represented. I think, forget about the numbers, but just that 11 countries have sort of contributed to your registry, I think is fantastic. It just, that is the most exciting part of the whole project. Because that just suggests that this can gain incredible momentum.
Yeah. Sorry.
Phoebe, can I just ask you something about your registry? Because I know you did contact me about this. The issue of ethics approval and informed consent. How have you been getting around that? South Africa is incredibly tight about this. We would have to, in our institution, as I explained, most definitely have informed consent and ethics approval. The other 4 South Africans or 5 South Africans, how have they approached this? And your colleagues from elsewhere?
So I did have a couple of replies from clinicians in, I think, other areas of South Africa who said exactly the same as you, that it would be very time consuming and difficult for them to get ethical approval because everything requires ethical approval. I think here, the way that I was able, so when I submitted the proposal for this registry as part of my overall ethics application for my larger kind of PhD project, and the way that I kind of got around it, I guess, is just to stress the non-patient identifiable nature of the information that's being collected. So first of all, that it's no identifying kind of details such as date of birth or address or anything like that are collected. It's just, this is a 57-year-old male patient from Lusaka or from even just Zambia who's got a diagnosis of ulcerative colitis, and the nature of the database as well. REDCap is a very sort of secure data collection tool, but even if it wasn't as secure as it is, I think the nature of the data makes it impossible really to identify the individual patient. So that's the way that I put it when I applied for my initial sort of ethics approval to set up the registry as part of my larger project. But yeah, I've had people really, actually mainly from South Africa, I have to say. I don't think it's been a problem elsewhere. And I'm sure that's just because of the perhaps more stringent ethics regulations where you are.
I'm sure you're aware of the secure database, which has been collecting international data worldwide on IBD and COVID. So they got around it by doing exactly what you said, by having sort of blanket ethics in a way, in that it's depersonalized data. So I approached our head of ethics at my institution to say, look, it's been considered acceptable in many other countries around the world, including, for example, the States, which is pretty, they're quite particular about their ethics. And he said, absolutely no way. Wants informed consent and wants a proper sort of ethics approval protocol, et cetera, et cetera. So it is tricky.
Yeah, interestingly, it was based on it's based on a database called the Pediatric IBD Network, which was set up by my co-supervisor, Professor Nick Croft in London, who runs the sort of project looking at adverse events of IBD medications in children, and that's kind of a Europe-wide thing, I think, and they also don't have the same issues with consent. So it's quite interesting how these things vary from country to country, and
unfortunate barriers.
Yeah, but Jill, it's interesting. You know, you mentioned the secure IBD and contributing to that. But you know, in South Africa, you don't need consent to register COVID patients in the country. No consent is obtained when the Department of Health publishes their stats on how many patients were identified. Now, I've raised that at a number of sort of meetings and said, you know, how come? And the reason being that it's become a notifiable disease. And therefore, legislation requires that reporting is mandatory. And that's artificial. You know, I just think that is an artificial sort of construct, that you nominate something a notifiable disease and suddenly all these ethical barriers fall away. And I just think that there's a logical problem with that, because you know, data is so vital to under-resourced countries. It is critical. And as we always say, you should be applying to ethics for not reporting your data, you know, explaining why you're not doing that. I understand all the protections, etc. But, you know, that's, so I'm surprised that the secure IBD was declined, because in the country, COVID is notifiable. Very surprised that was declined.
Yeah, they are quite stringent. Smita, you've had your hand up for a bit, and then perhaps when you're done, Yao, I don't know if you want to make any comments or if you have any questions. Smita?
Yeah, thanks. No, I like the concept that's going on in India, and I would love for our countries to adopt this. They have what's called an MRP, and it's the minimum retail price, which is put on the drug itself. And basically the idea is that if more people can access the drug, the cheaper it is. So, you know, they force the hand of the drug companies to lower their prices so that more people can have access to this. And I wish more countries would sort of adopt this. I think Kenya probably will take forever to do that because of vested interests, but you know, the idea is very good. Just a comment.
So, Smita, I mean, just to pick up on that, you know, in the early 2000s, we had unaffordable HIV medications beyond the reach of most patients. And through patient advocacy and a lot of work by, you know, opinion leaders, you know, drug monopolies were disrupted, prices were brought down, access was suddenly available to everyone. These things can take, you know, where one just needs the sort of weight behind these initiatives, but there's a precedent for this, you know. But
just like hepatitis C as well.
Sorry, just like
hepatitis C.
Correct.
The drugs, you know, they're very affordable.
They are. Yao, did you have anything that you'd like to say?
I think it plays around the demand and supply issue and advocacy on the side of medics. What I've realized is that currently we're having increasing numbers of inflammatory bowel disease, Crohn's disease, ulcerative colitis. And I think I've always said before I had my training with Jill and the team in South Africa, I think my diagnosis threshold was very high. And since we've been back, we've done lots of training, education. Many people are diagnosing a lot more ulcerative colitis. We are also seeing the Crohn's disease. And now we are approaching pharma. So recently I got a call from Johnson & Johnson saying that we can have a discussion on reducing the price for infliximab. The last time, I think in our discussion, David also talked about biosimilars, and I was trying to find out ways to go around. How do we get around it? We had a company called Ferry. They are bringing Pentasa into Ghana now. And recently they engaged us, and they were also talking about, well, if we have the patient, then they are ready to actually reduce the numbers. So I think it's a bit of demand and supply and advocacy, demonstrating that these patients are actually there and they need help. I think before it was considered as a disease of just some few people and that the pharmaceutical companies were not interested. So those who were bringing in for pure business and gain. But I think now most of them are actually listening to us now.
How many new cases do you think you're diagnosing per month, Yao?
That's difficult to tell. I may have to look at other centers, but currently 3 main centers are capable of doing that: Kumasi, Accra, and some private facilities in Accra. In my clinic, for instance, what I've realized is that in every month, I see about 2 ulcerative colitis. So far, I've only had 3 Crohn's disease patients since I've been back. I mean, it's been years, but I've had only 3 Crohn's disease patients. But I've had many ulcerative colitis patients. In a month, 1, 2 each month I see that. And I'm sure it's the same in those other bigger hospitals, 3 other hospitals in Kumasi, Accra, and some private hospitals as well.
So that's at least 100 per annum. So I mean,
yes, most likely will be.
Chris, what did you want to say?
No, I just wanted to apologize to Yao. I left you out, Yao. Thank you very much for your presentation and welcome.
Thank you, Chris. Thank you.
Yeah, can I maybe ask a question? I mean, you know, you say training, people to recognize IBD, but I would suspect in many developing countries, a lot of education amongst surgeons is needed, because they will probably often be called in to see a Crohn's patient who's now got a crisis or an abscess or a fulminant colitis patient. And, the sort of education actually goes way beyond the gastroenterologist. And also I like your comment about the pathologist who didn't have confidence in the diagnosis. And I saw the description there, which looked like a classic sort of IBD description, but the pathologist didn't have confidence in the diagnosis. And that's just such an important comment that you made there about, having confidence in making that diagnosis.
Yeah. But Dave, that's not unique to Ghana. We see that all the time with the fence sitting from many pathologists.
Oh, yes, I'm sure.
Non-specific colitis.
It's safe.
So when it happens like that, colleagues who haven't had a lot of exposure to inflammatory bowel disease, can I say a big thank you to Jill and the team in Cape Town? I mean, they made a lot of impact in my life when it comes to that field. And so if you send, let's say the surgeon does, apologies to the surgeons on the platform. In our part of the world, a lot of surgeons actually do the colonoscopies more than the medics. So a surgeon does it and does the biopsy, and then the pathologist says non-specific colitis, may not refer to us as a physician to continue. And then it changes direction. But I was convinced based on the history that I had taken. And so when it came as surgeon, he had described clearly in his report, like florid granulation tissue and all that. And then finally ended up, so I was convinced that this is, so I went ahead, I called them and I actually told them that I think this is Crohn's colitis. You should actually go ahead and call it. We had a discussion on it. We've not been able to meet behind the slide here to have a discussion. And so what I mean is that with this, I mean, a lot of diagnoses are being missed. And David said it rightly, especially the Crohn's disease patient. I think they will be with the surgeons in most of the time, especially those who are presented with intestinal obstructions of so many forms, except those who are fortunate to present with the Crohn's colitis, maybe some perineal disease with diarrhea as a component, then they may end up with the physicians and the diagnosis will be made. So Crohn's is one of the challenges. For ulcerative colitis, it looks like so far it's been great colleagues doing a lot of colonoscopies and histologies, and we are diagnosing quite a number of them.
I wonder if anybody else has comments or questions or experiences to share in their center. We've got quite a good few people online, so thank you so much for joining. David, Jill, did you have any other comments that you wanted to bring up from what has been discussed?
No, I'm just trying to think how we can go forward with this battle with the biosimilars, because I think that is the key thing that's come out today. Here we have fantastic drugs. Yours just presented 2 cases where people's lives have been completely changed. We shouldn't be practicing IBD from last century. These are not that expensive anymore. So I don't know, Dave, I think a lot of this is going to fall on shoulders like yours to get patient advocacy going.
Absolutely.
Or in fact, drive it from here with our contacts in industry here, I think. Because a lot of what they deal with is Sub-Saharan Africa. There's just not the appetite. When I ask them, there's not really the appetite and always the TB risk. But that's a secondary issue.
We've learned to manage that, Chris.
I'm saying that's the answer they always give. But I think in the new year, perhaps we could, you know, make this a formal project and see what the appetite is for driving it from South Africa into Sub-Saharan Africa, and also inducing competition.
Mm. No, absolutely. No, I think, you know, these platforms are definitely the way to drive it through these organizations, and to deal with local industry here and say, we have, you know, colleagues who need these drugs, and push it from here. We're happy to do that.
A lot of them are sponsoring Gecko IBD. And just, if I may just mention that next year, as we've said, Jill and David and Masheko, we will be changing the format of IBD Gecko. It will be case presentation driven from Sub-Saharan Africa rather than the other way around that we've been doing this year. It really has been a warm-up year as far as Gecko is concerned. So these, we're going to ask, you know, our various colleagues, Yao and Smita. And then it will be very nice, Phoebe, if you update us every few months or so on what's happening. If we can have this kind of forum and I will make sure that industry comes on board and are aware of what's happening, I think we'll have a good anchor in which to drive the availability. And we can actually become the activists. I mean, we are getting a little old for activism, but you know, the drive never dies.
We can do our kind of activism. Well, I mean, if there are no comments or anything else, we've got time to spare. David, I don't have any experience with this. Are there any laws in South Africa where government can force funders to fund certain things if they're given evidence for the benefit for patients? So, or are they a completely separate entity that sort of governs and regulates itself?
It's actually, the legislation is very clear. There's a number of conditions that are called prescribed minimum benefit conditions. And by law, every funder has to provide care for these conditions. So the typical ones would be hypertension, diabetes, ischemic heart disease, etc. Crohn's disease and ulcerative colitis are P&B conditions. And if you read the legislation, the Healthcare Act, it is clear in black and white that there should be no co-payments, the treatment should be provided. Then the funders came back and said, well, this is not entirely true, and that we will only recognize treatments that are available to the general population. So if a particular treatment is available in the public sector, then we will consider that okay to be funded as part of P&B conditions. So surprise, biologics are being used in the public sector. And now there's a sort of, so we've got some cases that we've taken to the Council of Medical Schemes where funders have refused to comply with the legislation.
Yeah.
And we've got one next week coming up with a colleague who's been denied treatment. And
I've heard of many cases where they're actually...
So the legislation is there. It's just that, you know, the resources required to challenge funders is enormous. And as individuals, you're really going to be up against big organizations with deep pockets. And you know, so that's the problem. But the legislation is very clear. There's no, and maybe Derek Burns might be able to, because I see he's on the call, and he's worked for some of the funders. But that's the legislation, and it's there. So, you know, it's
really hard work. I mean, if like you had to write 50 letters. I mean, imagine the time investment just to do that for one patient. It's incredible.
Sometimes it's the stress, and you actually see your letter in a newspaper, on the television, and you know, it's like, oh, this patient needs something. Sometimes it's a bit distressing, but I think in the interest of the patient, we actually go ahead to do. I'm very interested in these biosimilars. What we've been able to do on patient basis. So I think from next year, we can start a discussion from here, where there are biosimilars in South Africa, how we can access it for our patients on case-by-case basis before they get registered. We've done some work with our FDA here, and usually when we have a programmatic approach, they're able to actually allow the drug in without a full registration, since it's registered and being used elsewhere. So I'll be very interested, especially for my 3 Crohn's disease patients who are on now, and they are struggling every day. When it's like 2 weeks to time, I get calls every other day. do you know any big person who can help us get the money to buy it? Finally, they go around and they get it. So far, they've been going on, but I think a time will come, they will not be able to do that. So this biosimilar project, I'm very interested in. I really want to push it.
I 100% support that, yeah.
Well, colleagues, I think we could go on and on, but of course, time is against us. So I'm going to hand over to Jill to do the closing. Thank you.
Will do. And Dave, just before I do, I'm not sure if you're aware, but I have submitted to have biosimilars on the EML. So the moment that is approved, and I've written the thesis, they can't turn it down. Once that's approved, I think it's going to make life locally a lot easier for us, and hopefully that will also filter out to our colleagues in Sub-Saharan Africa. There's nothing like hoping. Okay, so to close the session, I'd just like to say thanks, of course, to Dave for putting it together, and for wonderful talks from Phoebe, Jo, and Smita. Thank you for joining us. I'd like to thank ECHO University of New Mexico and ECHO India team. Feedback forms are available in the chat, and recordings are also available on the Gastro Foundation website. I'd also obviously like to thank Chris and the Gastro Foundation, Cheryl and Karen for putting together the logistics. And finally, very importantly, thank you to all our sponsors, Takido, Asina, Amgen, Equity, Aspen, and Adcock Ingram. And with that, bid you farewell, have a good evening, and we'll see you in 2022.
Thanks.
Thanks.
Thanks, Jill.
Thank you.